Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the first week of January 2021. And as you all well know, the country and the world at large are not doing well with the COVID pandemic. Specifically in the United States, as of just a half hour ago, we are at almost 21 million total cases from the start of the pandemic, compared to a global total of 86.1 million. We've had over 355,000 deaths nationally. And again, this is as of just a little while ago from the Johns Hopkins data page. Focusing on pediatrics, specifically through the weekly AAP reports. This is through the end of the year 2020. In pediatrics, we've had a total of 2,128,587 cumulative pediatric cases. This is a total of a percentage of the total of 12.4%. Specifically in Arizona, from the start of recording, we have had 79,067 total pediatric cases. This is birth up to age 20. This accounts for 15.4% of our total in Arizona. On a rate per 100,000 children, that's 4,300 cases per 100,000 Arizona children up to age 20. Compare that to the national of 2,828 per 100,000. We've had a total of 14 deaths attributed specifically to COVID-19 or its comorbidities. So the numbers are up there. According to national and international media, Arizona's attack rate and our R-naughts are at the top of the world once again, even though our total numbers are not as high as some other parts of the country, e.g. California, the percentage attack rates are significantly quite high. So it looks like we'll be doing this podcast for a while yet, even as we encounter hope with the rolling out vaccine campaign and hopefully the start of a warmer season, which may help a little bit. Some excellent questions once again. Thank you all for sending those in. Please keep them rolling in. Ask me anything. If I can answer it, great. If not, I'll pretend or I'll do something like that. But these questions I think we have a pretty good handle on. The first one has to do with quarantine recommendations from the CDC, and this has been a shifting target over the last several weeks and months. The specific question has to do, though, with the healthcare worker who themselves may be asymptomatic but is exposed to a young child or a known case at home. Now, normally, the current CDC recommendations are that one needs to self-isolate or self-quarantine for 7 to 10 days after the date of last exposure to a known infected individual from the time that they were infectious. So that would be fantastic. However, unfortunately, healthcare workers who have children at home who need ongoing care cannot exactly self-isolate from the infected child. So they're going to be starting their time of self-quarantine from the last day of infectiousness of that index infected child, meaning 10 days after the child became symptomatic and or was diagnosed, then the healthcare worker starts their quarantine period. On the old recommendations, that was going to be an additional 14 days, so a total of 24 days away from work. With the new recommendations for the public, that would be a total of 17 to 20 days, depending on whether the healthcare worker, after their exposure, after the last day of exposure to the child, can then self-quarantine and be tested and be negative. If so, that's 7 days from the last day of contact, so a total of 17. If they cannot be tested, or if the test results are not back yet, or whatever the answer might be, then they need to self-quarantine for a full 10 days after day of last exposure. That's 20 days. Now, the current CDC recommendations for healthcare providers are a little bit different, and my suspicion is that they have not yet been updated to reflect the general public recommendations. That the current, on their website, CDC recommendations still suggest 14 days self-quarantine from day of last exposure, so the old way of doing things, meaning that any of us, if exposed to a sick child at home, could be out of commission for 24 days. However, my interpretation is a little bit different, A, because of what we know about viral mechanics and the degree of being contagious, and B, there's a nice, I won't say escape clause, but a modifier, which is in areas or situations where there is a decrease in available healthcare staff and therefore a need to try and get them back into the healthcare field more rapidly than normal, then the modifications can be applied. So, to the first part, we know from pretty reasonable data that patients who are known to be infected are expressing active culturable, meaning contagious virus, for really no more than 90 hours or so. So certainly, 5 days after onset, individuals with COVID-19 could be considered non-contagious. The 10-day recommendation, however, doubles that, and that's quite reasonable. In any public health emergency, one wants 2 lifespans, or in this case, 2 contagious periods out from point of contact to consider it to be safe or safer to return to return out of quarantine. So that therefore means, though, I think that the ability to shorten the self-quarantine period makes a lot of sense if the healthcare worker truly has not been exposed. So to the second point, looking at a 7 to 10-day home quarantine after exposure versus the 14, there's no reason that I can find in the literature, and certainly not scientifically, for why a healthcare provider would need to have a longer period of self-quarantine after an exposure compared to John Q. Public. Potentially, one could argue, well, the healthcare provider is working in a protected field with patients who themselves may be sick, and so would want to be extra specially cautious about being completely free of being infectious. However, given that we are all wearing masks in the healthcare field, even if one were asymptomatic and infected on day 11 after exposure, the chances of transmitting that virus to a susceptible patient are very close to zero. So I would argue, and I think it's a reasonable interpretation, to apply the same general public recommendations to the healthcare provider. So to try and summarize, because this is complex and confusing, it's a shifting target, as I said before, healthcare workers need to quarantine for at the least 7 days with a negative test obtained day 5 of that quarantine after their last day of exposure to an infected index case at home, especially if that's a child or a spouse or partner or something like that. So that's a lot better than the 14 days plus 10. That's going to be helpful. If, and this is the final part of the question, if that healthcare provider develops active disease or infection while they're in quarantine, then the rules change. They now need to quarantine for 10 days from onset. So the initial exposure recommendations go out the window, and we now have somebody who's actively infected. Then the clock starts ticking from day of onset of symptoms and or day of diagnosis, whichever is first. So hopefully that made sense. If not, please send in the questions for clarification, and I'll try and make more sense of it. Next question has to do with the coronavirus variant. This is the newest in the long now line of mutant strains of SARS coronavirus 2. This one initially described in the United Kingdom, although it actually probably started in parts of Africa as well as in London. The official recognizer for this strain is the B117 strain. So this is SARS coronavirus 2. It has had yet additional, this time multiple mutations in the gene encoding the spike protein, meaning that part of the SARS coronavirus which attaches to its ACE2 receptor. And in this mutant variant, like the one currently circulating through the country, that being the D614G mutation variant, there is thought to be increased infectiousness, meaning a higher number of patients who may develop disease after exposure to an index patient with the mutant strain. So it does appear to be more contagious. Reasons for that, again, are still being fleshed out in virology labs. One suggestion is that the virus binds with differing, not necessarily higher, but maybe lower, but differing affinity to its receptor in the respiratory epithelium, thus allowing a higher viral load, meaning that those respiratory droplets, which we all sneeze and cough and speak or sing out in the community, may carry a higher infectious load and therefore be a greater risk to somebody who walks into that mist. That may well be. That may well be. And if so, then we can anticipate a change in the contagiousness and the risk, I should say, of our pediatric patients. Current thought process from all the large population studies has continued to be that kids age 10 and less, or actually I should say less than age 10, have only a 5% risk of being contagious in the community or in the home setting. And that has been used significantly in our return to school discussions compared to children aged 10 through 17 who have a higher infectious risk even compared to young adults. Those numbers may well change if we're now dealing with a mutant strain that binds to respiratory epithelium, meaning in the nose, the back of the throat, etc., with different affinities, knowing that in general, younger kids, how to put this mildly, are snottier than older individuals. And so their chances of having uncontrolled respiratory secretions are higher, just like we experience with rhinovirus, with RSV, with influenza. Insert all those other normal respiratory viral infections, which we usually deal with. So it may be that the B.1.1.7 variant or mutant variant is going to behave a little bit more like typical influenza and rhinovirus in its degree of being contagious in younger patients. That remains to be seen. This is just me hypothesizing out loud. The important thing to keep in mind, though, is that even with this mutant variant and the others which have been demonstrated and confirmed, it is no more virulent. If anything, there are some of the mutant variants which have been less virulent, less causing less severe disease. Obviously, we are all in a setting where our ICUs are near or over capacity. We have a whole bunch of sick and dying patients out there. So any slight decrease in the virulence of a mutant virus is really a moot point. But in case the question comes up, that this is not like the super strain, which is more contagious and kills everybody that it infects. No, the degree of virulence, the degree of disease inherent to the new virus appears to be at the very worst, no different than what we currently have been experiencing, and maybe even a little bit less severe. Fingers crossed that holds true. Okay, next question. I'll just read this one. It's easier to get the whole thing. So this writer says that their local vaccine distribution location is recommending that everyone takes an NSAID like Tylenol or ibuprofen before their second dose of the COVID-19 vaccine. This provider appropriately usually recommends against routine use of Tylenol and ibuprofen, and is worrying about a blunted immune response if this hasn't been studied in trials. So this is a great question, and it is certainly a topic of current research. The current thinking, and that's about as far as it goes, because there has not been deliberately focused research to answer this question. But the thinking is that use of something like acetaminophen or a salicylate, not that we would use aspirin in kids, but just thinking of the adult patient population, or ibuprofen or other sort of versions of antipyretics, should not have a significant negative impact on the immune response to a vaccine. Certainly, when the vaccine is something like either the Pfizer product or the Moderna product, both of which are messenger RNA vaccines, which are going to be really, really good at causing the body to produce the antigen, to produce the spike protein, which should drive a robust immune reaction. So even if there was a theoretic slight blunting of the immune response, it's highly unlikely that would alter in any significant way the efficacy of the vaccine. All that said, that has not been studied specifically. So the current recommendations by the CDC and by the American College of Immunization Practices, so the federal recommendation is that individuals not take acetaminophen or ibuprofen prior to the day of vaccine. Certainly those products can be used after the vaccination to address post-vaccine reactions. Yes, absolutely. But there is A, no proven benefit for taking the product prior to vaccination, and B, there's a hypothetical potential decrease in outcome of the vaccines. Certainly as we start to roll out the non-messenger RNA vaccines, such as the AstraZeneca product or the Johnson & Johnson, Janssen Pharmaceuticals, both of those are adenovirus vectored vaccines. And it could be that use of a normally non-virulent vaccine to deliver the spike protein could be negatively affected by use of acetaminophen or ibuprofen just from normal viral transmission burden. So my thoughts, based on what little we know scientifically, would be to say no to that local vaccine distribution location and recommend that our patients not take acetaminophen or ibuprofen prior to the vaccination. Afterwards, fine, go ahead. You'll definitely wish to have something to deal with any rigors and myalgias which you may experience. That's a nice segue actually into current understanding of side effects from the vaccines. This hasn't been asked, but I imagine that many of us have those questions. Indeed, as we now get more experience in a public arena with the Pfizer vaccine first and now rolling out with Moderna, most people indeed are commenting on that injection site tenderness, no more severe in most cases than that after the influenza vaccine. Some have experienced a slightly more significant reaction, which they liken closer to the adult varicella or zoster vaccine, the Shingrix. I personally would say that my local reaction to the Moderna vaccine as part of the trial was closer to what I recall from the Shingrix vaccine. So it definitely, I was aware of it. That's after the first injection. There have been some individuals who have had several days of malaise, fatigue, and even flu-like illness after the first injection. In general, that is not the case, but up to 10 to 15%, this is my own personal observations, have commented on a flu-like illness after the first injection. Those who've had even a more severe reaction after the first injection may well have been infected with or exposed to the coronavirus prior to the vaccination, and actually may be having a great vaccine take unknowingly because they were previously infected. But there's no way to tell that after the fact. After the second injection with either Pfizer or Moderna's product, one A can anticipate a sore arm lasting for a couple days, and B can definitely expect at least 24 hours of at the very least some fatigue and malaise, and perhaps at the very worst, rigors, myalgias, arthralgias, very much the flu-like illness, which everyone has commented on in the vaccine trials. The good thing here, folks, is that it lasts only 24, at most 48 hours. That's fantastic if you compare that to the horribleness, the morbidity, and the mortality of actual COVID. So I'm saying this only to start to prepare us for the vaccine conversations, which we will hopefully start to have, certainly with parents of our patients, and as the current predictions are hopefully valid, we'll be having these conversations with our families as we start to vaccinate 12-year-olds and up by this summer in anticipation of the next school year. Yes, that timeline still remains accurate. Pfizer, Moderna, and now AstraZeneca are all recruiting age 12 and up into their vaccine trials for safety and efficacy. That data is anticipated to be presented to the FDA for a pediatric indication, age 12 years old and up, by late spring. So fingers crossed that this is so. No, it's not the younger kids, and hopefully not much will change in terms of the contagiousness of even the variant mutant vaccines, viruses. And so vaccinating the young kids won't be as necessary, but we got to start someplace. So anticipate pediatric indication later this spring. That's the fingers crossed. Okay. One or two additional questions just related to safety for vaccination. And again, this is based on what I've received as I volunteered to immunize patients against vaccine. Individuals who are pregnant have now been given the green light for vaccination. So too those who are actively working on fertility issues or trying to get pregnant. And so the vaccine, both products, Pfizer and Moderna, appear to be safe in the obstetrics and gynecology world for those dealing with active pregnancy or a wish for fertility. Okay, the last question which I have here, this is an individual who experienced palpitations and premature ventricular contractions, so PVCs, after receiving one of the messenger RNA vaccines. And the writer is asking, is this episode consistent with a post-COVID vaccination reaction? The short answer is, well, anything is possible. The cardiovascular sort of dysrhythmias, PVCs, palpitations has not been reported as a major side effect of either vaccine product, major meaning occurring in 5% or more of the vaccine recipients, nor even as a moderate, meaning occurring in 2%. So of course, any product anywhere is going to have at least intermittent reports of any symptom. And so if one looks very closely at the recent publications in the New England Journal of Medicine about the side effects, what one does not see prominently displayed anything about cardiovascular complications. That said, again, having been in a drive-through shot clinic for 2 weeks, we had a fair number of individuals who did experience palpitations, and they also ultimately were having symptoms and signs of anxiety. Which came first? Hard to say. It is entirely possible, given all of the background and all of the concerns about a brand new vaccine product and the pandemic and everything else, that our patients and our families and ourselves will experience some normal degree of anxiety. We did send several vaccine recipients to the emergency department for evaluation, similar to the question writer, and their cardiovascular evaluation was normal as well. Does that mean it was anxiety? No, absolutely not. I think it just means that we don't know what we don't know. The very best thing that I could say right now is that cardiovascular complications, i.e. palpitations, tachyarrhythmias, PVCs, or anything, have not been reported as a frequent or even moderately common complication of the vaccine. And when they do occur, so far they appear to be occurring sporadically. Fingers crossed that remains the same as we vaccinate more and more of general public, especially those who are not as medically versed, who may not know how to interpret what it is that they're feeling. So, folks, that's what we've got. Keep those questions coming. Thank you for listening to ID Talk. AZAAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, hang in there, folks. Keep fighting the good fight. Keep breathing. It's 2021. It's time for a new story. Thanks.